Welcome to the Occupational Disease and Return to Work Strategies for Success webinar. My name is Tanya, and I'll be moderating the session and handling the Q&A today. And our presenter is Dr. Sharon Switzer-McIntyre. Now, Dr. Switzer-McIntyre is a physiotherapist and assistant professor in the Department of Physical Therapy at the University of Toronto. She is the Vice Chair of Education, teaches in the musculoskeletal area, and leads the internationally educated physical therapy bridging program. She's an active member of the orthopedic division of the Canadian Physiotherapy Association. So I'll hand it over to you, Sharon.
Thank you, Tanya, and welcome everyone. Thank you for tuning in to have a dialogue about something that's become near and dear to my heart, which is the whole area of occupational disease. It's not an area where I would say rehabilitation professionals work predominantly, and I think it's an area that we have a huge role to play within and contribute to. So what I'd like to do today is talk a little bit about the impact of occupational disease on workers' functional abilities and the impact of the disease on the individual's ability to work. And I want to house that within the framework of a couple of studies we've done recently that are focused on occupational contact dermatitis of the hands. But I think that they are a great opportunity to look at some of the issues with a collective group of individuals who can sometimes see that direct link between what's happened within their workplace and the diseases of the skin that they are acquiring. And then I'd like to talk about some strategies to assess viability to return to work or sustain work or think about work in different ways. So let's start with some definitions. I feel it's really important to start with some overall definitions so that we're grounded on what we mean when we talk about occupational disease. So let's first of all think about what is occupational health. When we talk about occupational health, I think about it in two dimensions. I think about it with respect to the health of the people at work, and I also think about it with respect to the relationship between the work and the individual's health. And I know those may be slight nuances, but I think we need to really think about the population piece and the relationship piece. So I just have a graphic below that helps us really target some of that thinking around what's happening in the environment, what's happening with health, both at an individual level and at a population level, what's happening in an environment with respect to accidents and exposures, and what types of work are we talking about. I should have apologized up front. I am just getting over a one-week bout of laryngitis, so if my voice cracks, I'm going to apologize up front. I will try to keep myself lubricated so I don't crack. My speech and language pathology colleagues were saying, "You're going to do what today?" But I think I'm okay. So when we think about definitions that are used worldwide, that are established through the International Labor Organization. These were published in 1993 and still stand, so I thought we could use those as kind of our foundational definitions. So if we think about strictly occupational diseases, they're diseases having a specific or strong relation to the occupation and generally really only have one causal agent, whether that be a physical, a chemical, a biological, or a psychosocial, and we'll talk about what those four domains are in a minute. And these diseases are often clearly compensable. So when we think about our workers' compensation, workplace safety and insurance components, these are the diseases where when we can have a strong causal relationship with the work, then there's usually no dispute. We have work-related diseases where there might be multiple causal agents, where the factors in the work environment may play a role, but there may be other other risk factors, which whether they be still within the work environment or within the individual or the environment globally, that contribute to the development of a disease. And then we start to have some fairly complex etiology. Some of our asthma, some of our respiratory conditions can fall into this particular area. They become not as clear-cut with respect to, is this a work-related, solely work-related disease or disorder or not? And then we have diseases that affect the working population, so we come to our population level, where the causal relationship with work may be there, but may be aggravated by other external factors, may be aggravated by hazards that then can compromise health. So some of our chemical spills are great examples of diseases that affect working populations overall. So if we look for one clear, concise, and succinct definition, a disease contracted out of or in connection with work that is characteristic of that work or directly related to the risks specific to that work is what we mean when we talk about occupational disease. And disease, in my mind, often I put in quotation marks because some of the diseases and disorders that we talk about within the occupational disease rubric, sometimes I question whether I would call it a disease, but they are certainly considered that within this framework and rubric. And that's partially because of the 4 types of occupational diseases that we talk about. When we think about these 4 types, we have diseases that are only occupational in origin. Excuse me, I'll have my little sip. And some of those could be related to our asbestos issues. So asbestosis is something where if someone has an exposure while they're in the workplace to asbestos, there's no question that that occupational disease has had its origin rooted in the work. Occupation is one of more of a causal factor, so some of the occupation is one of just the causal factors. So some of our individuals who are predisposed to asthma and then are exposed to irritants in the workplace, which may exacerbate that asthma or take it from a low-grade, no-intervention type of respiratory issue into something that is much more prevalent and much more prevalent when the individuals in the workplace is an example of a causal factor. Occupation that has the occupation as a contributory factor could be something like our hand-arm vibration syndrome factors, where there are maybe some compromise in circulation, let's say, to an individual that's predisposing, and then we put them into environments where there's a vibratory effect or there's a swing in the temperature that may start to irritate the underlying vascular issues. And then occupation that's aggravating a pre-existing condition. So we could think there of potentially our carpal tunnel syndrome individuals, or individuals who have low back issues and then go into the workplace and end up with increasing loads on the tissues within the low back. So when we think about occupational disease, we think about it from the 2 main elements that are present in the definition. So the causal relationship between the exposure in the specific working environment or work activity and a specific disease, as well as the fact that the disease occurs among a group of exposed persons with a frequency that is above the average morbidity of the rest of the population. So again, when we think about the occupational disease rubric, we need to think about not only the individual but the population as a whole. So if there is a percentage of the population that's exposed to those irritants, will they develop a disorder or a disease? So occupational disease is not solely about the exposure. It's about how does that exposure overlay on the population overall. So when we think about the burden, it's important to think about how prevalent are occupational diseases. Well, if we think about it from the perspective of, again, the International Labor Organization, and I've taken this from a 2012 publication of theirs, where they looked at fatal accidents and they looked at fatal diseases. So if we think about accidents versus diseases, and we're not thinking about injuries here, we're thinking about diseases, there were 321,000 fatal accidents, yet there were 2 million fatal diseases. So it's a significant hidden epidemic. It has significant challenges. When we think about the burden overall worldwide, 1.9 to 2.3 million deaths can be attributed to occupation. 1.6 million deaths can be attributed to work-related diseases, and 217 million of those cases can be just occupational diseases overall. So it's, as I said, one of those hidden epidemics. It's there in the workplace. It's difficult to to determine some of the causal factors. So many of these individuals go for long periods of time without diagnoses, or even they're in latency, so we don't know that they've had an exposure and a resulting disease until they're closer to the end of their lifespan. So we know that in developing countries, occupational injury and diseases are much higher than in North America. The health and safety standards in North America and most of Europe are very high. Therefore, we have a higher recognition. We have a higher opportunity to surveys and surveillance opportunities within North America and most of our European counterparts. But when we look at the United States, we've got about 400,000 new disabling cases of occupational diseases reported a year, and about 100,000 deaths from those diseases, with, as I said, about 10 million occupational diseases that occur worldwide. The other piece we need to think about is that the occupational diseases, which is somewhat different than some of our occupational injuries, may affect multiple organ systems. So when we look at generalized costs with respect to diseases, and I've kind of picked and placed this from a number of different pieces. If we look at just our musculoskeletal, that's a huge chunk of what we think about when we think about work-related injuries, is that 40, depending on the numbers you look at, could be 40 to 60% of all of our costs. When we look at all of the other pieces, though, we've got 60% that we're dealing with, where we're dealing with some heart, we're dealing with mental disorders, which fall under our occupational diseases, we're dealing with respiratory disorders, we're dealing with the central nervous system, we're dealing with some cancer, tumors, which are on the rise as opposed to on the decline. So this pie gets sliced very differently when we start to add in what is happening with respect to the occupational disease arena. If I take a snippet from our own Ontario scene, which is the Workplace Safety and Insurance Board, and we look at 2012, we can see that overall there were 195,000, almost 200,000 registered claims that were registered with the Workplace Safety and Insurance Board in Ontario. Of those, there were almost 17,000 that were considered occupational diseases. So 8% of all claims registered in 2012 were related to an illness or a disease, as opposed to an injury, which was more focused on the musculoskeletal system. So it's not, in reality, a small problem. It's an issue that, as I said, the rehab professionals probably don't deal with as much in their day-to-day practices, but really we should be, and with the challenges with diagnosis, it becomes an issue. So how do we determine whether a disease is related to work? And as I said, there's often a huge stumbling block with respect to function and ability to work that gets tied into this process for the worker themselves, and can take years to determine what the causal factors are. So many of us see these individuals with complaints and symptoms, but we often don't tie that back into a strong occupational history, which looks at the description of all the jobs that they've held. So again, if we look at someone who's later in life and complaining of respiratory issues, it's important to go back and do a detailed job description of all of the jobs they've held, because are we seeing someone now who has issues related to asbestosis? And why is it important that we tie the causal factor to the job? It's because the compensation issues that then, and the compensation support that then tumbles out of that particular diagnosis. We need to understand the work exposures. We need to understand the trajectory of the symptoms. When did these symptoms come on? When are they stronger? When are they weaker? If I take 3 weeks off, do my symptoms go away? If I'm away for a month, do my symptoms go away, or do my symptoms get worse? Do my symptoms come on when I walk through the halls of my place of employment, or do my symptoms get worse by the end of the day? So understanding that symptom pattern and trajectory. Understanding what's going on within other colleagues within a workplace, understanding the epidemiology of the symptoms and the illnesses across the population, and understanding what other non-work exposures and factors may contribute to the problem. So if I'm at work and things get worse. When I leave work and I go to certain other areas or environments, do my symptoms get better or do my symptoms continue to escalate? So if I'm I'll take occupational contact dermatitis as an example. If I'm a hairdresser and while I'm in the workplace, every time I do a color, I color someone's hair, my hands get worse. And then I go and I am painting at home and my hands get the same redness, tightness, irritation. What's the link between those two? What toxic substances are within those two particular environments that may be creating a problem for me? When we think of occupational hazards, there are 5 categories that we really think about these hazards in. There are our physical hazards, which are our hot, our cold, our environment. Are we working at heights? Are we exposed to sunlight? So sunlight, and then if we're exposed constantly to the outdoors, what's that doing from a disease perspective when we think about some of our skin cancers and skin disorders? Are we exposed to chemical hazards? So are liquid cleaners, vapors, gases, paints, any of those types of toxic exposures? Biological hazards, viruses, bacterias, bloodborne, any of the bloodborne types of diseases. So our SARS example from Canada is another good example of a biological hazard that created all sorts of occupational diseases that we needed to deal with. Mechanical hazards such as any moving parts that may be affiliated with a job or a job task, some of our vibration exposures, some of our ergonomic issues. And then our psychosocial hazards, so our stress, harassment, those types of issues which can create occupational diseases with respect to mental health disorders. So what are some of our predominant diseases? So we've got diseases of the nervous system or the sensory organs where we have hearing, so our noise-induced hearing loss. If we look at our data with respect to compensation costs across Canada in particular, we know that hearing aids as a compensatory response to exposure in the workplace are one of the highest cost items within the compensation system. A completely preventable disorder, disease, and it's called the disease. Noise-induced hearing loss is one of those pieces that we can be tracking and we can be preventing if we control the amount of noise within our environments. If we look at diseases or disorders of the musculoskeletal system and the connective tissue, those are all of our itises. We can throw hand-arm vibration syndrome into this domain. Hand-arm vibration syndrome is one of the diseases that crosses multiple organ systems. So in order to have a diagnosis of hand-arm vibration syndrome, we need the musculoskeletal system to be affected, we need the vascular system to be affected, and we need the nervous system to be affected. So we need to think about that particular disorder across multiple dimensions. If we think of diseases of the respiratory tract, these are things like our asbestosis, our asthma, our silicosis. Many of those diseases, asbestosis and silicosis in particular, have long latency periods, so they may not show up upon first exposure or even short-term exposure. And some of them, like asbestosis, may not even become prevalent until the individual has long been out of a particular environment and exposure. Sorry, excuse me. Our neoplasms and our cancers, our mesothelioma, our malignant tumors are also in exposures that have long latency. Some of our firefighters and the exposures that they have that are unknown until we start to look at our population data and look at individuals who are involved in a particular fairly large fire, or individuals who are involved with a number of different forest fires. We start to then see that there are some trends, and then we start to dig with respect to, okay, what are the specific exposures that may have all of these individuals presenting with cancers who have similar types of occupations, which then speaks to the importance of having large databases where we hold this data so we can start to understand some of our trends. And then contact dermatitis becomes a really good example of some of our skin or subcutaneous tissue diseases. And I'll be using that particular group to give you some examples of what we mean when we think about some of the occupational diseases and why the occupational diseases start to really affect the worker at a functional level and at an ability to work level. In the clinics that I work at with, and I'm associated with at St. Michael's Hospital here in Toronto, we have three primary streams that we work with. We have multiple streams, but our three primary streams within the Workplace Safety Insurance Board specialty clinic framework are contact dermatitis, asthma, and hand-arm vibration syndrome. So we've been doing a lot of research lately looking at how does function overlay disease. One of the pieces that I think is most prevalent within the occupational disease area is the primary focus, and rightly so, has been on the diagnosis, the medical diagnosis, and not so much with respect to looking at function and overlaying function, which is where my interest has bubbled up. And we know from our individuals who visit our various clinics that it could take 3 to 5 years for an individual to be referred to the clinic for a consult to actually start to look at, are the symptoms, are the collection of symptoms that these individuals are presenting with related to the workplace. So I'm going to take you through some highlights of a couple of studies that we've done recently. One looking at hand and upper extremity function in workers with hand dermatitis. And what we wanted to do here is gain a better understanding of the functional compromise of the hand and any coexisting functional compromises, the upper extremity, that may exist for workers who are presenting with contact dermatitis of the hand. And what we found was that the patient's voice was very strong. We did a number of functional tests, and we did, I'm not going to present that data today, but we did definitely see that there was a huge functional compromise that had a direct impact on an individual's ability to work and their ability to sustain their work and their ability to even change work within not only their own workplace but professionally within different workplaces. But what I wanted to pull out for you today, because I thought it had complete or specific relevance to our talk about work and sustaining work and thinking about how do we wrap our heads around these individuals who for the most part are in the system with looking for and confirming diagnosis of causal relationship to work and what that means to their function and their ability to work overall. So the patient's voice was very strong in this study where we did, as I said, a number of functional tests, and we also asked them some very qualitative based questions about how do they perceive their hands affecting their ability to function and their ability to work. And what we heard was that housework was affected. So even when they use some sort of protection, it limits their ability to do what they need to do, and they never feel that they're clean. Their social and leisure activities. They can't go ice fishing. They can't work in their garage. They can't play their guitar. We can take that to the level of the individual with the cancer or the respiratory issues, and the same issues come forward where their social and leisure activities are limited. Specifically for the individuals with contact dermatitis of the hand, they get cuts, they get cracks, they've got open sores, they're afraid of getting a disease because they feel like they've got this compromise already. They try to use gloves and cream, and they're tired of explaining, why do I always have to look different? Why do I have these creams on? Why do my hands always glisten? Why am I always wearing gloves? So the gloves and their creams create a barrier for them from the perspective of being a viable individual within society and also an individual who has the ability to fit in. Their daily activities get compromised. Driving a car, holding a dog leash, some of the things that they do that everybody else can do with ease are now difficult and embarrassing for them. And the issue about chronicity is one that transcends all of the diseases, which is when their hands aren't good, it's difficult for them to explain why their hands aren't good. It's unpredictable. There's no clear trajectory that if I do this, then this is going to happen. So even stress becomes one of those issues that starts to create a flare. When we looked at their quality of life, what I wanted to just stress with you is that their symptoms are significant, but the social pieces, the functional pieces with respect to being embarrassed and their ability to work and study were their three tops. So not only was it symptoms, it was their social being, and it was their work and leisure activities, which were the most affected for them. When we looked at the SF-36, which is a general health questionnaire, and compared the Canadian norms to carpal tunnel and to our population, what we found very strongly was, yes, they had physical compromise from the normal population. What became quite interesting for us was when we looked at their vitality and we looked at their social functioning and their role emotional and their mental health, those were the things that were falling well out of line of Canadian norms and those with carpal tunnel syndrome. So it's that stress and strain on the not only the physical functional component, but also on their mental health component. So they have so that those individuals that are in the more occupational disease arena tend to show more areas of stress and stress-related disorders because we feel somewhat that there's the longer course to diagnosis, and there's the latency issues that get tied into that as well. Another study that we did was looking at the nature and extent of disability as experienced by people with occupational contact dermatitis to look at the physical, functional, and social consequences. And what we did with this study is we mapped our findings onto the WHO model of the ICF model. So we looked at body functions and structure. We looked at activity, participation. So we looked at them from a functional level. We looked at some of their personal factors and their environmental factors. And again, this maps well onto other occupational diseases. I'm just using the occupational contact dermatitis as a model because I think it's an easier one for many of us to wrap our heads around. So when we looked at body function and structure, the symptoms are persistent, they're cyclical, and there's remission and relapse. Again, this fits well with some of our respiratory problems and some of our neurological problems that we see with respect to the workplace. And we've just provided some quotes from the various individuals to support why we've placed things where we've placed them. So when their skin is dry and flaky, it's cracky and bleeding, they report some symptoms. They can also report periods where they've got no complaints and are able to then be in the workplace, which speaks to the challenges of being in and out of the workplace frequently. And not only what does that do with respect to work sustainability and work viability, but also with some of their role issues and their social issues. So with respect to activity, they experience severe limitations in activity due to these recurring symptoms. And their ability to participate, they become disengaged sometimes from some of their physical work and social activities to prevent the flare-ups. So it's not that they're flaring, it's that they start to withdraw somewhat because they are concerned that if they do engage, then they will create some sort of flare. And that's something when we think about work, return to work, and viability that's really important for us to consider along the continuum of work. When we think about some of their personal factors, the frustration of living with an occupational disease can lead to depression, anxiety, and decreased self-worth. So something, again, with this category of individuals, we need to, as healthcare professionals, be always assessing and reassessing and considering what element of the mental health component is prevalent within the diagnostic process. We need to look at the environmental factors and be clear, or as clear as we can be, at what are the irritants, what are the causal factors that create the problem that the individual is experiencing. We also went on to look at, because these individuals are in the system often for long periods of time, what kinds of management issues do they experience? And what we found was there's what we call the professional management, or we could call it the medical management, where it's focused on let's manage the disease or the disorder. And what we found is that they also have a very strong element of self-management. There's a huge level of frustration within this population, so they try to manage it themselves. They try all the various creams and potions and motions to see if, you know what, I've tried avoiding, I've tried using barriers, I've tried doing all sorts of different things and they're not working. So maybe there's some other potion that I could try that could help me. And certainly with the availability of information within the great World Wide Web and Dr. Google, we know that these individuals across the occupational disease categories are trying all sorts of different types of management strategies that may or may not complement the medical management and the healthcare management that they're receiving. So the take-home messages with respect to this piece that where we looked specifically at the occupational contact dermatitis is that there are issues that transcend all areas of function, functional ability, activities of daily living, work, and work viability that we need to consider because of the cyclical nature of most of the diseases these individuals get exposed to. So I want to spend some time talking about how do we go about assessing individuals for their ability to work and for their function. And that comes back down to some very significant health management measures that we need to make sure we put in place. Pre-employment screening, where we look at these individuals in a manner that's not to be exclusionary, but is in a manner to be comprehensive, to make sure that we understand what types of exposures they may have had in the past, which comes back to our very clear occupational histories. We've done some studies recently where we've looked at how well do our healthcare professionals, we looked at a variety of healthcare professionals, take occupational histories, and how well do they integrate those occupational histories into their routine assessments of individuals. And what we found is that across the board, very few healthcare professionals specifically think about taking detailed occupational histories. Those who have specific training in the area obviously are including occupational histories, but if we look at the general population of most of our healthcare professionals, it's not a priority for them. Periodic health examinations. We need to really ensure that the general population think about their periodic health care examinations and that they think about their work in relationship to their health. Our whole health promotion strategy, health education strategies need to integrate work into the rubric when we think about health, and how is work as a very significant determinant of health playing into your overall health and well-being. So again, targeting that population piece. Thinking about specific protection strategies in the various workplaces. If we know we have a workplace that has risks, what are we doing with respect to protection, and how are we ensuring that that protection is being used in a manner that truly does protect the individuals in the workplace? And ensuring that the risk assessment of the working environment is occurring on a regular basis within our workplaces. So do we have routine strategies in place within workplaces to ensure that risks that may or may not have existed previously are being assessed on a regular basis. Are we looking at our overall populations and ensuring that if we start to see more claims being provided within a particular area in our workplace, are we going back in and looking at risk assessments? We see employers on a fairly regular basis who may be risk-free at one point, and then they change the supplier that they're using for a specific agent or chemical, and then all of a sudden complaints and symptoms bubble up. So there's something going on within that particular environment where we need to go in and do a risk assessment and figure out why do we have complaints at a population level that are bubbling up to the surface. Looking at the pre-employment health care exam, we really need to, again, focus on that to determine whether there are physical and emotional capacity of the individual to perform the job. So does the job fit the individual? We want to look at what baseline health data there is for the epidemiological and legal purposes. So again, from an employer's perspective and from an insurer's perspective, having that epidemiological data is important to know. So if we think about our causality piece within the occupational disease framework, we need data to actually say that yes, in fact, an exposure to asbestos when someone's 20 could lead to asbestosis and potential death when they're 60 or 70, and that individual does actually require and is eligible for compensation for that end-of-life period. That's very important to them. We need to be able to counsel individuals for disease correction, habits which may harm them later. So we need to be careful that if individuals need to be protected, if we know, for example, that someone who has contact dermatitis and that we know a specific exposure may be an irritant for them, what are we going to do to protect that individual? If we know that there are specific agents or specific irritants within a particular paint that may cause respiratory distress for an individual who's predisposed to asthma anyway, what are the respiratory precautions that that individual will take if they're in the workplace to ensure that they don't exacerbate their asthma? And then assessment for pre-existing toxicity and impairments due to any past exposures. So helping individuals understand their vulnerability, their prevention, and their protection. So it's a really, really key area where education is fundamental and foundational. The periodic health care examination needs to have a focus on that evaluation of general health status and the trajectory of general health over the course of a 24-hour period, of a 1-week period, so that we can actually incorporate what's happening with respect to an individual's general and overall health and how that relates to their exposure to work. When we have periodic health examinations where we are thinking within those frameworks, our likelihood of early detection, control, and hopefully prevention is much higher. We can detect any deviations in health deviation from baseline data, which is important, detect any infections or communicable diseases which may affect others, which is also important. So coming back to our SARS example. The cyclical nature of the diseases and the latency of diseases is again something that with periodic healthcare examinations we can start to pick those issues up and start to maybe not do anything specific about the disease at that point, but really start to pay attention to the systems that may be affected and act and interact quickly and easily with the healthcare system and the insurance system to make sure these individuals are set up for success as they move through a potentially inevitable disease process. When we think about work and functioning within work and what this means to these individuals, I like to think about it in a framework of the worker, the workplace, and the work. So when we think about the worker, we need to think about the worker from their general health and well-being. We need to think about the worker from what they may or may not be predisposed to. We need to think about them from an anthropometric perspective. We need to think about how do they fit into that workplace and the work. When we think about the work, We need to think about what are the potential exposures specifically related to that work. And are those exposures, when we're thinking here about the physical, the chemical, the biological, the mechanical, and the psychosocial, are those exposures compromising that worker in any way, shape, or form? We then need to overlay the workplace within that, because we could have a worker who is in a job where the exposure in that specific piece of work is compromising the worker, but there are other components and opportunities within the workplace where they may be able to go and work. We've had some cases where we've had workers who are in respiratory distress because of the exposures within their workplace. They've been out of the workplace for long periods of time. The worker has brought them back into the work, or the employer has brought them back into the workplace, and they exacerbate. They exacerbate because they not necessarily are back in that same position, but they're physically close to that exposure. So it's the closeness to the exposure that ended up being the problem. And we've worked very closely with our industrial hygienists to try and tease out, why have we got this person back into the workplace? They're doing the job that they're trained to do. We've eliminated what we know are the irritants, but they're exacerbated. It was because of proximity. So we need to think about the overall workplace as well, and how is that workplace interacting with the worker and the work. So if we go to the 7 principles of successful return to work, which the Institute for Work and Health has published and is readily available on their work site, they've done a great deal of work at looking at the literature and morphing and continuing to update what they're thinking about with respect to successful return to work. Now, these are usually targeted specifically at the musculoskeletal arena, but I think as we look at them and look at the 7 overall principles, they completely overlay what we think about when we think about occupational disease. If we overlay on top of that framework the conceptual piece of latency and the cyclical nature of some of these diseases. So any workplace needs to have a strong commitment to health and safety, which is demonstrated by all the workplace parties. Modified work or alternative work, some sort of accommodation that could facilitate early return to work, we know enhances the ability and the success rate of return to work. We know that there needs to be some sort of an individual who's the ambassador who ensures that there's a good and succinct return to work plan in place. We know we need to have supervisors on board so that they understand what the issues are. And this doesn't mean that we need to divulge diagnoses, but we need to make sure that those supervisors understand that an individual, if we're returning them to the workplace, especially when we're talking about some of the disease issues where exposure is one of the fundamental principles, that proximity to exposure is important. So it's not the task, it's the exposure that's important. Early and ongoing contact is something that we've all known for a long time is important and just makes sense. The coordination piece is important, and that we've got ongoing communication is also important. So those 7 principles apply across the board, whether we're talking about our more robust population of the musculoskeletal individuals who are in the workplace, or those individuals who experience occupational diseases within the workplace. So if we think about this, and what does this all mean, and how is return to work different with occupational disease, I think the fundamental pieces are that occupational disease has a long latent period, and it can be cyclical. So these diseases don't often just crop up over the course of a 6-week exposure. They're diseases, most of the diseases have a very long period of germination coming to a conclusion that the causality lies within the workplace. So they often cause a challenge with respect to assessment and treatment. If we think about exposure and we think about proximity, we need to think about it differently than we think about exposure to a task, and think about it with respect to how far may a toxic substance or toxic chemical travel within a workplace and therefore where do we position a worker within the workplace to make sure that they don't or are not exposed to that particular chemical, vapor, gas, whatever it might be. In some situations, it may occur among the general community as a consequence of contamination. So we have multiple examples across Canada where we have workplaces where there were chemicals, and asbestos again is another great example of this, where asbestos may have attached to articles of clothing and then it was taken home. So we have communities who are affected by disease where it's not just the worker, but it may be the worker's family, because an individual within that home may have been the one who was washing the clothing, let's say. And so the asbestos was dislodged when the clothes were being shaken out and put into the laundry. And therefore the asbestosis was now not only in the worker, but also potentially a diagnosis that bubbles up in a spouse or family member. I think what we also need to think about is, for the most part, all occupational diseases can be prevented, and what are the roles that all of the various players have in ensuring that prevention is of our utmost of mind at all times. So the key elements to consider are determination of baselines. We need to know baselines. Noise-induced hearing loss, as I said, is a great example that's probably in the forefront, or should be in the forefront of all of our minds, as we have our personal music devices lodged in our ears and the volume turned up, and we're diminishing our baselines very early on, and there's some pieces of work that are currently going on across Canada and Europe right now looking at our youth with respect to their noise-induced hearing loss, and what does that mean to our global baselines once they come into employment. We need to determine the work-relatedness of our particular symptoms that people, signs and symptoms that people present with. We need to continue to monitor and continue to think of work as part of the rubric of our health assessments. We need to continue to consider the three factors related to work, so the work, the worker, and the workplace. And we need to continue to foster commitment from employers, workers, and healthcare teams to ensure that we're sustaining viable work. And the work may look different for someone who has an occupational disease versus someone who has an injury, and in particular musculoskeletal injury, as a result of the type of work that they're doing. So hopefully we've thought and talked a little bit about some of the impact of occupational diseases have on functional abilities, the impact they have on an individual's ability to work, and I've helped you think about some of the strategies that you can use to assess viable return to work options. So some closing thoughts that come from a variety of patients that we've talked to with a variety of different types of diagnoses in the occupational disease arena. I feel like a freak. Doctors dismiss me. I fear of losing my job. This came from an individual who was in our general occupational area and had a variety of signs and symptoms that ended up being rooted in the cancer domain, where their symptoms changed frequently just because of the nature of the disease that was brewing, and people, they felt, didn't believe them. And it was a very complex, multifaceted problem that was rooted in exposure to the workplace. No one understands that some days I feel great and others I can barely get out of bed, let alone work. So again, speaks to that cyclical nature of the occupational disease. And it basically affects all aspects of life, including dressing and caring for my 2-year-old son, dressing myself, tying shoes, sexual activity, household chores, household maintenance, playing sports, and my ability to work. So these individuals have, within the occupational disease framework, their functional compromise goes well beyond just the workplace. So with that, I see we have 10 minutes left, so I'll open it up to questions.
Great, thank you very much, Sharon. I was curious during your presentation, in talking with the workers and with interviewing the workers, did you find that they commented commonly about their employers and how their employers, or how they feel their employers view their occupational illness as compared to with other people who get a explicit injury on the work site, like on the job?
That's a great question and an ongoing challenge because the illness is often, the occupational disease is often, there's no physical sign. It's not, above and beyond contact dermatitis of the hands, there's often not a physical sign. There might be weight loss, there may be fatigue, there may be all symptoms that the patient feels that people can see, but there hasn't been a specific incident where the employer can say, oh, well, Sharon, you lifted a box that was too heavy and of course you hurt your back. These symptoms creep up over time, and one of the issues that becomes prevalent is there's often more than one person in the workplace that may have similar categories of issues, but they present quite differently. So it's an ongoing challenge where they're in and out of the workplace, they're in and out of doctors' offices. They are challenged with respect to, is there truly a link? Is my work making me sick or not? Is an ongoing challenge for this particular population. And determining causality is a challenge for all of us with respect to when was the exposure, how were you exposed. For other things, it may be quite evident that there was an exposure depending on what the incident in the workplace is. So it's a very difficult relationship sometimes with the employer.
Yeah. We did get one question, someone who's asking, can you speak more to the psychosocial hazards and ways to assess and address these so an employee doesn't end up with an occupational disease, mental health issue?
That's a whole other area that's significant, and I would say bubbling up. We've worked with a couple of employers looking at, is there a way to do a mental health demands analysis within a workplace? And there certainly are some examples of employers who are trying to do that in their workplaces. It's difficult in a 2-minute answer to actually address that, but certainly being aware that there are individuals who may or may not be in environments where the stresses are so strong that they can continue to dismiss and continue to work within the environments. So it's that piece of when you're at work, or when you're thinking about work, or when you're doing things associated with work, do your symptoms escalate, and how do they escalate, and why do you think they escalate, is a really important avenue to explore with patients and workers to ensure that they are also aware that the exposure within the workplace may be what's creating their problems. What we find with many of these individuals is it's difficult for them to articulate and make that leap to, this is an exposure within the workplace that's creating my issue. So you have to really work with your individuals to try and chip away at that and understand exactly what the exposures are. And that exposure may be a relationship with an individual, a close coworker, a supervisor. Maybe they're in a client service relationship and it might be a client, and understanding what that exposure is and legitimizing for the individual that that is a legitimate reason for a mental health, perhaps depression type of diagnosis and scenario, and then helping them understand what does that mean. And I think for all of these particular diseases, education is of the utmost importance.
Very good. And thank you everyone for being here, and thank you Dr. Switzer-McIntyre for the presentation.
Thank you.